Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in Easy Endo Prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. Today, we will discuss chronic kidney disease in the setting of type 2 diabetes. Chronic kidney disease remains one of the most impactful complications of diabetes. In the United States, close to half of all individuals who progress to kidney failure have underlying diabetes. Once CKD is identified, treatment strategy shifts. Glucose control is obviously important, but medication selection is driven by organ protection, not just blood sugar control. The goal becomes slowing kidney decline, preventing progression to end-stage kidney disease, and reducing cardiovascular events. SGLT2 inhibitor therapy is the backbone of management in type 2 diabetes with chronic kidney disease. These agents consistently demonstrate strong renal protection across multiple trials, with about a 38% reduction in composite kidney outcomes. That includes slowing decline in glomerular filtration, reducing progression to dialysis or transplant, and lowering both kidney-related and cardiovascular death. The benefits extend beyond glucose lowering. Hemodynamic effects at the glomerular level, reduction in intraglomerular pressure, and modulation of tubuloglomerular feedback all contribute to kidney protection. From a practical standpoint, this class should be initiated early in any patient with type 2 diabetes and chronic kidney disease unless contraindicated. Agents with the strongest evidence base include canagliflozin, dapagliflozin, and empagliflozin. Remember the letters C, D, and E. Understanding GFR thresholds is critical because they determine when to start and when to continue therapy. For glycemic effect, Cana, DAPA, and ER2 are used at GFR 45 or above. Empagliflozin is typically used at GFR 30 or above. However, the cardiorenal benefits extend much lower than those glycemic cutoffs. Clinical trial data support use down to GFR of 20 for most SGLT2 inhibitor indications related to kidney protection. Dapagliflozin can be used at eGFR 25 or higher. Empagliflozin can be used at eGFR 20 or higher. This distinction is important. Glycemic threshold should not limit initiation when the goal is renal and cardiovascular protection. Finerenone adds another layer of kidney protection and is particularly relevant when albuminuria persists despite optimized therapy. Finerenone is recommended for patients with type 2 diabetes and chronic kidney disease with greater than or equal to 25 and urine albumin to creatinine ratio greater than or equal to 30 milligrams per gram. Mechanistically, finerenone reduces inflammation and fibrosis at the level of the kidney and cardiovascular system. Clinical outcomes show reduced decline in kidney function and slower progression to end-stage kidney disease, along with lower risk of cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. Layering therapies is increasingly supported by emerging data. The Confidence trial evaluated the combination of finerenone with empagliflozin. The combination resulted in greater reduction in albuminuria compared to either agent alone. This supports a model where SGLT2 inhibitor forms the base and finerenone is added when albuminuria persists. This is not redundancy. These drugs act through different mechanisms and provide additive benefit. GLP-1 receptor agonists play an important supporting role, particularly in patients with combined kidney disease and cardiovascular risk. Their benefits include reduction in albuminuria progression, slowing decline in kidney function, and reduction in cardiovascular events. They remain effective at low kidney function levels, and can be used down to an eGFR of 15. The FLOW trial provides strong evidence for semaglutide in kidney disease. Semaglutide at 1 milligram weekly reduced kidney failure, significant decline in GFR of at least 50%, kidney-related death, and cardiovascular death. Additional benefits included reduction in all-cause mortality and reduction in major cardiovascular events. This expands the role of GLP-1 receptor agonists beyond metabolic control into direct kidney outcome improvement. When managing a patient with type 2 diabetes and CKD, therapy selection should follow a layered, outcome-driven approach. Start with SGLT2 inhibitor as foundational therapy. Then assess degree of albuminuria and residual risk. If albuminuria persists, add finerenone when criteria are met. If cardiovascular risk is high or additional benefit is needed, add a GLP-1 receptor agonist. This approach addresses kidney protection, cardiovascular risk reduction, and metabolic control. CKD and diabetes requires proactive management. Waiting for creatinine to rise significantly or for symptoms to develop results in missed opportunities to slow progression. Therapy should be initiated early, even when kidney function appears relatively preserved because structural and hemodynamic changes are already underway. Monitoring should include GFR trends, urinary micro or macroalbumin, electrolytes, especially potassium when using finerenone. Dose adjustments and follow-up intervals should reflect kidney function and risk profile. For this episode, remember these medications: canagliflozin, dapagliflozin, empagliflozin, finerenone, and semaglutide. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.